Hi, everyone. We're going to wait just a couple minutes to allow folks to join this session. While we wait, feel free to take a moment to post in the chat where you're located. Okay, we can get started. Hello, everyone. Thank you for joining the Marfan Foundation for this webinar titled Applying the AHA Scientific Statement, Navigating the Diagnosis and Management of Pediatric Aortopathy. I'm Lauren May, Director of Research at the Marfan Foundation, joined by my colleague, Dr. Josephine Grima. As you may know, the American Heart Association, or AHA, published the first comprehensive expert consensus scientific statement on pediatric aortopathy in August of this year. The statement, which was authored by a committee that included 10 leadership volunteers from the Marfan Foundation, covers multiple conditions, including Marfan syndrome, LDS, and VEDS. Today, we are fortunate to have two of the statement's authors and members of the Foundation's Professional Advisory Board with us, Dr. Shaine Morris and Dr. Ron Lacro, and they will cover the most important information to come out of the statement. Before we kick off our talks, Michael Weimer, the Marfan Foundation's president and CEO, would like to say a few words. Michael?
Thank you, Lauren. Good evening, everyone. Thank you for joining us this evening. I actually just wanted to come by and say thank you for all the support and interest you share in the Marfan Foundation, whether you have Marfan, Loeys-Dietz, VEDS, or one of our other related conditions. It's always great to have you with us, and we really appreciate your support. As we look out over the next few months, we have 18 support groups that are meeting regularly. We have 3 upcoming in-person educational events, and we also have 4 virtual educational events, all happening between now and February. Also, if you want to mark your calendar early, July 10th through 13th, our in-person conference will be in Atlanta, and it will include our traditional health fair, which is very popular. So again, July 10 to July 13 in Atlanta. We also have some updated websites on the horizon and a new Marfan Foundation app. So you should be seeing those in the second half of this calendar year. And our Help and Resource Center has really never been more popular. So don't ever hesitate to reach out to Stephanie or Jan or our team for support in any way it may be helpful. Most importantly, thank you for joining us tonight for this special presentation by 2 great members of our Professional Advisory Board, Dr. Shaine Morris and Ron Lacro. Enjoy the holidays. Thanks, Lauren.
Thank you, Michael. So I'm going to introduce our speakers in just a moment, but before I do that, a bit of housekeeping. For this webinar, we will use the Q&A functionality built into Zoom to field any questions you may have for today's speakers. Please select the Q&A tab on your screen to submit your questions, and we'll cover as many as possible at the end of the session. Please don't use the chat to submit your questions because we may miss them in some of the communications there. And also, this webinar is being recorded and will be posted to the Foundation's YouTube channel in the next several days. I am honored to introduce both of our speakers today. Dr. Shaine Morris is the Medical Director of the Cardiovascular Genetics and Fetal Cardiology programs at Texas Children's Hospital. She's also a member of the Marfan Foundation's Professional Advisory Board. Dr. Ron Lacro is an Associate Professor of Pediatrics at Harvard Medical School, is the former Director of the Aortopathy and Connective Tissue Program at Boston Children's Hospital, and is also a member of the Marfan Foundation's Professional Advisory Board. Dr. Morris, Dr. Lacro, thank you so much for joining us today. Dr. Morris, would you like to kick?
Sure, absolutely. Let me just share my slides. Well, thanks to everyone who's joining us. And I know some people will be watching later recorded. We're not going to go over every single detail of the statement, but more how to use the statement. Why did we do it? What's included? Where can you find resources if you're looking for information in the statement? So first of all, why did we put this together? Well, we know that aortopathy, which is, a word that means it encompasses various conditions that can lead to dilation, aneurysm, dissection, or rupture of the aorta and blood vessels. And we had very little guidance for care in this in children, even though more and more this is being diagnosed in young people, especially with the advent of less expensive and more available genetic testing. And the pathogenesis often includes genetic conditions, and these can really help. Knowledge about these genetic conditions can help us manage patients. So the aims of this statement were to provide a general framework for cardiac management of aortopathy in children. Dr. Lacro and I and many experts in this arena will often get calls or emails, what should I do about this? And there wasn't really a consensus. So we wanted to just say, here's a framework of how we should apply these different things, whether it's imaging or surgery or medication or exercise, and then how can that be modified based on the individual characteristics of the child and their family. We also are really aiming to reduce variation. Our team did a survey a few years ago of providers in the United States, and the practice variation was really broad in all of these arenas. And we wanted to try to narrow that variation a little bit so that we can learn more as we go through patients and their outcomes. So just a clarification, sometimes these are called guidelines, and I wanted to clarify. So this is the official title at the top, Cardiovascular Management of Aortopathy in Children, a scientific statement of the American Heart Association. So the AHA, which is one of our major parent organizations, does both guidelines and scientific statements. Now, there was a guideline for adult aortopathy, most recently published in 2022. That's the top one, ACC AHA guideline for diagnosis and management. This has more strict guidance for what you should do with levels of evidence. You need lots of data. And we just didn't have enough real data, real science in children to do levels of evidence and do a guideline. So ours instead is a scientific statement, which is basically a consensus statement. I'll show all the authors in a minute, but we got statements of experts in many different disciplines that take care of children with this to come up with our best opinion. And certainly when there was data, that was incorporated into the statement, but there wasn't sufficient statement to do a guideline. Also, the 2022 guideline for adults is 149 pages, and we were much more limited. Ours is only 27 pages, and we had a very strict word count. So you'll see that we augmented the statement with use of a lot of tables and supplemental data as reference for practitioners. And the main audience for this is practitioners who take care for children with these conditions. So this is the statement. You can see that we had authors from all over the country in different arenas. We also had an expert group of reviewers that are listed here, and many of you will recognize these names. So this is the main outline of the statement. So the first part of the statement is evaluation of the child with suspected aortopathy. So this goes through, what do you do if you have a child with aortopathy? What should be included in the history? What should be included in the physical? What are key things to look at in the patient to help you come up with a diagnosis? The next section is imaging. What imaging should be done? How often? When should we do MRI? When should we do CAT scan? We're going to go over all of these. The next section is genetic testing. What genetic testing to do? How to make a diagnosis? How to evaluate the family? Then we have a section on medical therapy. When to use medicines? How often? How to dose it? Exercise and activity, and Dr. Lacro is going to go through this, but this is very different than what's been published before, and I think hopefully encourages kids with these conditions to join activities much more often. There's a section on aortic dissection and when to do prophylactic aortic surgery. And then after all of these, we have gene-based sections, specific sections on each genetic condition, highlighting some of the unique features and unique therapies for those patients. So just to give some highlights, this is big picture, taking a step back of the imaging table. Here, we'll do a zoom up. But the imaging table, basically, it characterizes, so across the top, says, do we have no dilation? It's based on the degree of dilation of the aortic root or the ascending aorta. So do we have none, mild, moderate, or severe? For kids under 16, this is based on a Z-score. If we go back for kids over 16, is based on absolute dimension in centimeters. but under 16 is based on the Z-score. And then we have each condition kind of labeled in the table. So this is an example showing Loeys-Dietz type 1, 2, 3, 4, and 5. And then there's a color code saying how often they should be imaged based on the dilation. So if you look at Loeys-Dietz type 1 and 2 caused by variants in TGF-br1 and TGF-br2, if they have severe dilation, this is a Z-score greater than or equal to 5, they should be seen every 3 to 6 months with imaging. And you'll see there's a lot of these little footnotes. And so this has a star, and it says, by the way, surgery is recommended at aortic diameter, absolute aortic diameter of 4 to 4.5. So if you have a Z-score above 5, but you're hitting 4, it's probably already time for surgery, and then this table is moved. So this has a really nice long table going through, again, all the different kinds of aortopathy and how often to image. So this is at the lower part of the table, this is showing some of the rarer conditions, filament A, the EFEMP2 and arterial tortuosity syndrome, which are ultra rare, bicuspid valve, patients who we think that there's a hereditary thoracic aortic disease, which is what we're calling aortopathy here, and congenital heart disease. And these are much more controversial. And so we have guidance on how often to image them as well. All right, we're going to move to the genetic testing part, and I'm going to pass it off to Dr. Lacro.
Good evening, everyone. So there is a section in the statement outlining how to do a genetic evaluation and when to do genetic testing. So in this figure from the paper, excuse me, we give the indications for when to do genetic testing. At the top of the table in the red, you can see the indications for testing, and on the bottom, you can see what we would do after testing. So in the bottom left, in the blue section, if we do find a genetic diagnosis by gene, then we can screen other family members using genetic testing. If we don't find a genetic cause, then we would screen with imaging for relatives that might be at risk for the aortopathy. Next slide. And here, in more detail, the indications for genetic testing. And we divided these for patients who have bicuspid aortic valve. This is a 2-leaflet instead of 3-leaflet aortic valve, versus those with bicuspid aortic valve versus those without. And then there are some conditions where we feel very strongly that genetic testing should be done. And at the bottom right corner, we see some situations in BAV where genetic testing should be considered. Next slide. And so for all of these slides, what we do is we basically provide a framework for how to manage patients. And this framework needs to be modified based on the specifics of each patient and their families. So just like the imaging table, this is our table for guidance for medical therapy. Recognize that most of the evidence that we have for medical therapy for aortopathy comes from randomized clinical trial data in Marfan syndrome. And often, not always, but often we use the experience in Marfan syndrome and extrapolate to other conditions. Just like the imaging, you see it towards the top of the table. In younger patients, we use the Z-score to categorize no dilation, mild dilation, moderate, or severe. In older patients, older teenagers and young adults, we would use the absolute dimension in centimeters. And the imaging table, we use a color code to indicate whether to use no medicine, one medication, either a beta blocker or angiotensin receptor blocker, or in situations where the aorta is more severe, we would use 2 medications. And the dark blue would be the situations where we would use 2 medicines together. Next slide. Here, just a little bit more granular data, just looking at Marfan syndrome and the various gene defects for Loeys-Dietz syndrome. Again, there are specific guidelines or a framework to work based on the genetic diagnosis, the size of the aorta, the age of the patient, and the rate of growth of the aorta as well. Next slide. Now, this is the table, as Dr. Morris mentioned earlier, we wanted to approach exercise in a little bit different way that has been approached in the past. A lot of the literature or recommendations in the past related to exercise has been more focused to highly competitive athletics and adults and older teenagers in particular. And our bias was to actually encourage healthy exercise rather than focusing only on discouraging various activities. So like the previous tables, we see the color code there. So a lighter blue would indicate a lower risk. The darker blue indicates higher risk and specific activities to avoid. You can go to the next slide, Shaine. And we divided our guidance based on the age of the patient. So we feel, the writing committee felt that it was very important to start discussing exercise even as early as preschool age. So there's specific guidance in terms of how to console by age, specific exercise and activity prescriptions, relating to routine physical activity as well as recreational and competitive sports. And because there are frequent questions about amusement parks, we did put some guidance in amusement parks about amusement parks as well. And then we talked specifically about the intensity of exercise and give specific guidance as to what kinds of activities to avoid, specifically things like heavy weightlifting, bodybuilding, heavy contact sports like wrestling and tackle football, for example. And then at the bottom of the table, we have specific considerations based on the more common diagnoses. So for example, in Marfan syndrome, we need to consider whether or not there is dislocated lens. In the case of vascular Ehlers-Danlos syndrome, we need to consider the risk of bruising and the risk for damage or injury to soft tissue and blood vessels. Next slide. And then there's a table on surgery, when to do surgery. Again, the lighter blue is standard risk. If there are high risk features, we would modify the recommendation for surgery. So there's a higher risk column on the right and a standard risk on the left. And you can see each of the conditions that we discuss in the paper along the left side. The recommendations for, thresholds for surgery here for Marfan syndrome, the standard risk recommendations are in alignment with the adult guideline, but we also give specific recommendations for younger children, which is not addressed in the adult guideline. And these are the different sections that are included in the paper. So you might imagine that the sections on Marfan syndrome, Loeys-Dietz syndrome, vascular EDS, and ACTA2 are much longer than some of the others where there's less information to talk about. So in addition to the general sections in the front of the paper, there are specific sections for each of these conditions. And towards the bottom of the table, we talk about a very common congenital heart defect called bicuspid aortic valve. So there's specific guidance related to that diagnosis. And then there's also a section for what to do in a situation where we know that there is aortic enlargement, but we don't know what the genetic cause is. And because of the strict word limit, the actual paper allowed only 7 tables. I think we included 7 figures and tables. We included an additional 14 tables and figures in the supplement, which is easily accessible on the website, the circulation website. So we talk about things like how these genes present during childhood. We can just go through there are different tables. I won't go into all of the specifics here. stop. There's figures on how to do the echo, how to do an MRI, how to take the measurements, recognizing that it's important to do these measurements in a consistent way. Probably the most useful supplemental table, I think, is the next one, Shaine. This one, yes. Yeah, so the second to the last one, we give, there's a table devoted to when to do CT and MRI. So it's generally less common to do, oh, there's the table, yeah. It's less common to do it for Marfan syndrome, much more common to do cross-sectional imaging, either a CT or an MRI with a Loeys-Dietz diagnosis, particularly type 1 and 2, or a vascular Ehlers-Danlos diagnosis. And then we have specific guidance for how to use the medications as well. So in summary, this statement is the first attempt at really putting everything about management of pediatric aortopathy in one place. It no doubt this will not be the last. I think as we learn more over time, we will need to revise this statement, but I think it's a good start at a consensus statement with input from many different providers across the country. And the goal, again, as mentioned earlier, is to sort of reduce variation in practice to align providers, and in so doing, optimize care and improve long-term outcomes for children with aortopathy. So we give specific guidance for when to image, when to use medications, which medications to use, when to do surgery, etc. We emphasize the importance of a thorough genetic evaluation and genetic testing when appropriate, because the specific genetic diagnosis is very critical in streamlining management and also improving outcomes. We discuss in great detail how to counsel families about exercise and physical activity, and really sort of emphasize promoting healthy exercise and incorporating shared decision-making with the patient, the family, and the medical providers. And finally, we focus on the importance of aortic centers with specialized expertise in aortopathy, particularly for patients that are at high risk. I think this document is meant not only for providers like Dr. Morris and myself, who see a lot of patients with aortopathy, but also for other providers around the country and the world who may not see as many, but importantly still provide care for aortopathy. But it's very important, especially if there is a high-risk situation, to consult a specialized aortic center. And is that the end? All right. So we have kind of buzzed through that, but I think that the idea is that, you know, our goal today was not to sort of go into every detail about this statement, but just to provide general information about it so that you, whether you're a provider or a patient or a family member, can work with your team to optimize management based on your specific situation, what your genetic diagnosis is, how old you are, how big your aorta is, how fast it's growing. And so the paper really sort of helps you as a patient or provider to get the proper care.
Wonderful. Thank you so much, Dr. Morris and Dr. Lacro, for sharing such important information with our community. Members of our audience have submitted a few questions for you, and we will go through those now. The first question we have is, on the table for imaging recommendations, where was the SMAD3 mutation?
I can show that. Hold on one second. Sorry, I have to go back a little bit. It's on there. They're just so big. This is for imaging, right? So SMAD3 is right here. So you can look, it's kind of similar to the other ones, just a little bit different guidance. for frequency of imaging. So it depends on the size of the aorta.
And age, right? So SMAD3 tends to present a little bit later, so we wouldn't recommend as much imaging in a very young child with SMAD3 as opposed to, you know, a young child with TGFBR1 or TGFBR2.
Right. You can see that it's different. They're kind of, you have to be bigger to do more frequent imaging in SMAD3.
Great, thank you both. What would be considered early onset Marfan syndrome?
I'm happy to address that. I'm curious, Ron. So there hasn't been a universal agreed upon way to diagnose it. It tends to be a collection of features that are much more severe, including mitral valve disease, much more severe skeletal disease at a younger age, and often lung disease. We did get together, a group of us, and write a paper maybe 2 or 3 years ago. Just we surveyed experts and said, if a patient had these features, would you call them early onset Marfan? And we made a scoring system and published that, and a score of 16 is generally where experts would put you. But usually you go to an expert and sort of this much more severe form of Marfan syndrome. Ron, I don't know if you want to weigh in.
Yeah, I think it's one of those situations, you know, like even in classical Marfan syndrome, there's a spectrum of severity. So there are some people with classical Marfan syndrome who have more severe issues or more complicated multiple problems, and then those that don't. With early onset, I mean, in the most severe cases, we don't have to even think about it, right? There are some kids that just present very early, have a lot of leaking of their mitral and tricuspid valves, which tends to be the more predominant early problem, and then also tend to have more severe non-cardiac findings as well. There are situations where, you get a young child who's sort of in the severe end, but don't sort of meet the criteria. So it is a spectrum, but I think the point here is to recognize that there are some kids that are more severe, and we definitely would adjust our management based on those findings. But it's sometimes hard to be sure, how to call it. In the past, we would use terms like neonatal Marfan syndrome or infantile Marfan syndrome. But I think the emphasis now is more on the timing of the onset of problems and the severity of problems. And if there are a lot of problems, particularly in the first year, it's more likely to be this early onset. But I think Dr. Morris's paper on the scoring system is very helpful because it makes it easier for us to decide, how to classify any particular individual. But in the obvious ones, it's pretty clear just based on the findings that we see.
Okay, thank you. Can you clarify what determines low versus high risk on the exercise table?
I can pull it up if you want to address it, Ron.
Yeah.
I know the font is tiny when we see the whole
The
table.
font's going to be a little tiny, but so for example, in the very middle of the table, there's a very dark blue colored thin strip when we're talking about competitive sports. So in this case, the severity or the higher risk is because of the nature of the sport. Heavy contact, heavy weightlifting, because of the risk of elevating your blood pressure with heavy weightlifting. That would be one situation. Further down, there's a dark blue box talking about strenuous training and prolonged physical exertion. Again, the heavy weightlifting is sort of a common feature. And then the other very dark blue box has to do with the setting where the sport is, right? So in this case, you can play basketball with your friends in a very sort of friendly recreational manner, and then you can also play basketball in the Olympics and in the NBA. So this, the exact setting, what the team is like and what the other players are like is very important in terms of deciding how high risk a situation may be. So all of these factors need to be considered. when talking about exercise. And we really recommend that exercise be discussed at every visit. Partly because it changes over time. So the age of your of the child really influences how you what that discussion is like. But it's also a difficult topic to discuss, and oftentimes it will take several visits and several discussions for everyone to really sort of feel comfortable with the level of exercise that everyone is that the child is participating in.
Thank you. We'll stay on the topic of exercise and activity. Any tips for discussing the exercise at the preschool age and also like with a child, but also with the school? What any recommendations there?
Well, yeah, I mean, I think it's actually important both as providers and as parents to bring it up. You know, a lot of times the restrictions that we see even in the table tend to happen in older kids, but I think it's good to sort of know what eventual limitations will be from preschool, so they are not falling in love and want to be a competitive football player. But sometimes we say, you know, at least, you know, we think you're really special. We think these are going to be good kinds of sports. And at a school level, mostly it's reassuring to the schools. Like at elementary school, there's very few restrictions as you look on this table. There's just a few things at preschool to be like, make sure you're in, you know, you're encouraging. And so a lot of it is the other side, people get very worried. And so I'm happy to talk to teachers or write a letter, like they can do anything, let us know, just call the parents if there's any issues. So it's more on the other side of like reassuring and making sure they're involved in PE at elementary school level and making sure that they're, you know, incorporated and not excluded. And then as they get older, you just try to guide them down different paths. But I think knowing this from an early age, just to sort of guide them into these non-competitive sports is good too. Or non-contact sports, not non-competitive.
Great advice. Thank you.
Yeah, I can add a little bit to that. I mean, you know, I think a lot, you know, the shared decision making includes sort of an assessment of risk, right? And I think those of us who take care of children have the advantage that the risk for aortic dissection, for example, is quite low in children. And so I think just sort of putting that out there and having parents understand that you know, as a child gets older or in adulthood, definitely the risk for dissection increases. And there are definitely situations where the risk is higher even in young children. But in general, the risk for very serious complications in most of these aortopathies, the risk is pretty low. One of the things that the paper includes is a table, separate table that just lists the high risk presentations. I think it's one of the nice things about the table. That table is it really sort of puts in one place all of the different situations where we should really adjust the way we think about it, right? So, for example, the kids with the early onset Marfan syndrome definitely have more tend to have more severe and more progressive findings. It almost defines the condition that they have, whereas most young children with classical Marfan syndrome have a very low risk of dissection.
Thank you. There are parts of the world where skiing is a way of life. What are your thoughts around counseling families with aortopathy around wanting to participate in downhill skiing, acknowledging that it's not a contact sport, but there is certainly a risk of falling at speed?
I mean, there's no data on this, so you can just get mine and Dr. Lacro's opinions. I don't think we specifically addressed it here. I usually, you know, talk about skiing as fine in most situations until you get highly competitive and not pushing people and making sure you're not, you know, trying too hard to do the black diamonds and trying too hard to go, you know, to like compete, go faster. But just skiing and downhill skiing is a way of life for many families and trying to gauge risk. I mean, anyone can hit a tree, right? And that's the biggest risk. It's not the skiing itself. It's the injury with skiing. And so I'm pretty liberal with skiing as long as we're not being highly competitive. But I'm curious, Ron, you're around a lot more people that ski. Most of ours, you know, wintering to Colorado down here.
Yeah, I agree with that sentiment completely. I mean, I think just emphasizing the recreational aspects and trying to avoid the mean, because skiing can be very rigorous and very competitive, but it can also just be a fun activity. So I would emphasize proper techniques and just general safety that which should be emphasized for everybody who's trying to ski, not just kids with aortopathy. But for most people in most situations, I think as long as you're not trying to be the fastest and the best and if if your goal is the Olympics, well, we need to probably have a discussion. But for most situations, I think if they learn good technique and adopt sort of safe practice, I think it's fine.
Sounds good. Thank you. Let's talk about amusement parks. What is doable there?
You want to start, Ron?
Oh, I lost my screen. Yeah, I mean, again, I think it depends. For most people, so I would focus on what the diagnosis is, what the age of the patient is, and how big the aorta is. If the aorta is not that big, I don't think that we have strong data to suggest that that is very high risk. If there's anything to avoid, maybe those activities with very rapid acceleration or deceleration. But I think overall the risk is pretty low. What do you think, Dr. Morris?
Yeah, I mean, I think the fear comes from there's been a handful of dissections reported on roller coasters, and think of how many millions of roller coaster rides happen every year. And there's been, a small handful, so there's a concern. And same as Dr. Lacro, I usually say most roller coasters are fine, but to, maybe avoid those, like the drops where you're dropping 7 stories, or the ones that are like the turbo that are extra fast with extra loops. But a lot of them, most of them, I sort of, we have zero data. No one's ever studied what rides did the 3 people who dissected on a roller coaster, what rides were they on and what was special about it. So we just say use common sense, but I don't limit too much except maybe to avoid those extreme acceleration, deceleration ones.
Makes sense. Thank you. Fencing. I don't know that fencing is on your list there. How would that fit into the categories here? There's obviously protective gear involved, but what are your thoughts?
I mean, again, it's going to be, you list every sport, it'll be more of a style thing. I don't restrict on fencing usually. They're so protected and it's not heavy contact. It is contact, but it's with, the tools. So I don't know, Ron, what you say.
Yeah, I would agree with that. I mean, I mean, again, there's different levels, right? So sometimes for me, the thought process is how hard is the training, right? So if you're doing fencing at the Olympic level, fairly recent, I think there were some Harvard athletes that sort of got pretty far this year, or Americans anyway. But but I think I certainly have had patients with Marfan syndrome who have fenced recreationally. I think it's a great discipline, and it's a technique-based sport and strategy. And so I think as long as the training is not very intense, meaning especially weightlifting, right? So I think for most people as a recreational sport, it should be fine.
Okay, we'll do 2 more activity questions and then we'll move on. Thoughts on recreational horse riding? Is that a similar mindset as the downhill skiing?
For me, yes, it's very similar. Try to just overall be safe and not have accidents, because those can happen in people without Marfan syndrome or other aortopathies.
Yeah, and proper training, I think, is important.
Okay. And then what about musical instruments? My middle school LDS 1 child was just told no wind instruments.
So I had a physician assistant working with me years ago who played the trumpet. And she told me that with good technique, you're really not sort of using really strong Valsalva. I mean, there's some trumpet players that look like they're blowing their head up. So, I think for sort of for most players, I would not restrict them from wind instruments. You know, there are people who are starting to do things like, measuring blood pressure and heart rate in a exercise lab, and that would probably be the best situation, right? So, if you measure one's blood pressure while playing the flute and it's fine, it's probably going to be fine. I wouldn't go crazy and, try to really wail on a trumpet, because I think that there are some really harsh notes, and there are definitely some wind instruments that require much more pressure than others. But I generally do not restrict flute, clarinet, and that kind of instrument.
Yeah, and in the same way, unless they've had a history of like pneumothorax or obvious blebs, or my most severe patients, like some Loeys Dietz patients are definitely more severe and have already had some sort of lung disease with either atelectasis or issues when they've had surgery, or like the early onset Marfan syndrome tend to have significant lung disease, but kind of your standard variation, Loeys Dietz and Marfan, I don't restrict either.
Okay, sounds good. Did you draw on guidance from other countries for the statement on diagnosis and management of pediatric or aortopathy? This is a question coming from someone in Ireland. They're curious if similar guidance exists where they are, or if they can use our statement in the US, the American Heart Association statement, to share with their care team.
We definitely know about some of the other statements. Vassern has one for Europe. That includes kids. I don't think it's dedicated to kids, but it kind of extends to the pediatric one, but it's not nearly as extensive. So I think at least, for some of our sections, we probably referenced it, but I don't think there's one dedicated to children, unless you know one, Ron. I know the most recent Vassern has it extends a little more into the pediatric. Vassern's a European one, a little more into the pediatric space than the 2022. We keep calling it the adult statement. It no longer says it's limited to adults, but most of the guidance doesn't make sense for kids. So it does have some extension, but I think Vassern more explicitly talks about some portions to kids, but nothing is quite as extensive as ours.
Yeah, I think that our international colleagues probably would welcome this statement. So I would share it with your provider, and we really would like to hear if there is very strong differing opinions from other parts of the world. I mean, Dr. Morris and I do work with other providers like ourselves from other countries, and I doubt that there would be huge differences in approach. But please let us know if you or have your provider call us if they have strong differences of opinion.
Thank you. What age should losartan be started, or is it just based on Z-score?
Well, it's both based on Z-score and diagnosis, and the minimum age you can start it as is 6 months old that it's sort of been approved for. But a lot of it is based, Dr. Lacro was the first author on a big randomized controlled trial in Marfan syndrome from a few years ago that showed basically the earlier you start medications, the better, in terms of reducing the rate of aortic dilation and the degree of aortic dilation. So, basically as early as possible, if you meet criteria for treatment, and with the earliest age being 6 months.
Okay. For the shared decision making, it would be helpful to know to know better estimates of the risk of aortic dissection in school-age children. I've been told by my child's cardiologist that dissection is very rare when the aortic root diameter is less than 4 centimeters. Even anecdotal data can be helpful if we don't have rate estimates. Do you see aortic dissection in school-age children with onset during exercise? If so, what is the aortic root diameter in these children that do have a dissection?
I've only had one dissection under 14, and that was in a 10-year-old with early onset Marfan syndrome who'd already had a root replacement, and he had a type B dissection, which is a dissection in the back. He was extremely severe and had a type B dissection and did survive that type B dissection, and it was not with activity. He was just playing with he was playing with his brother, but it was no big deal. It seemed to be pretty spontaneous. That's the only school age child. I'm curious because Dr. Lacro has been in practice longer than myself. And I've had a handful of later teenagers, only one of which was ACTA-2 and associated with running the bleachers.
Was the question specifically about Marfan syndrome or just a dissection in general?
Dissection in general.
Okay, yeah, I think I mean overall, and Dr. Morris has published on this, dissection is uncommon. It's definitely higher in certain situations. So it's very important to follow kids closely. In classical Marfan syndrome with an aorta less than 4 centimeters, I don't think I've ever seen a dissection. It's unusual even in adults with aortas less than 4 centimeters. There are some situations. The risk is different for Loeys-Dietz, particular TGFBR1 and 2. There are certain mutations with Loeys-Dietz. Depending on which amino acid your gene changes, I mean, your risk can be much higher. So I think it's just the trying to identify whether there are high risk situations, either because of the gene or because of the size of the aorta or the rate of growth of the aorta or the underlying diagnosis. If there's none of those, I think the risk is extremely low. And it's hard to give a number. But I think ultimately, just the fact that several decades of follow-up on the call right now, that we don't see dissection in these situations, I think should be reassuring. We still always, educate our families and patients about what symptoms to watch for and when to seek care and those kinds of things. But the likelihood of a dissection is extremely low all the way around. Even now, I don't want to scare people who have the diagnosis of Loeys-Dietz to think that the risk is very high of a dissection, because I think even the risk for Loeys-Dietz is low. It's just higher than Marfan syndrome, which is very low. If you don't have one of these really high risk features, I think overall the risk is very low, especially in a young child.
Especially with aorta less than 4 centimeters, I agree.
Yeah.
One caveat is vascular EDS, especially the more severe forms. I mean, aortic dissection is extremely rare under 10, but certainly starting around 12, they can just have spontaneous dissections with no trigger. So we're always pretty cautious in that population, the high risk patients with vascular EDS. But their aortic dimension doesn't matter. They just, the risk factors are different.
Thank you both. Does the statement include specifics on baseline imaging when newly diagnosed?
Yes. Let me see if I don't think I highlighted it. I can probably escape and show you guys the statement. Oh, it's in the supplement. Hold on, let me stop sharing. Let me find the supplement really quick. There is a really long, the table for cross-sectional imaging and for aortic imaging has a lot of detail about that. Ron, I don't know if you want to talk with that while I look. I don't have the supplement handy.
Yeah, so again, depending on your diagnosis and your age, we have very specific guidance as to what kind of MRI or CT to do based on your diagnosis. So for most people with classical Marfan syndrome, for example, unless there are high-risk features, we generally don't do an MRI. One situation where we would definitely have to do a CT or MRI if the echo was inadequate, right? So if we can't really get reliable measurements of the aorta by echo, which happens sometimes, we would have to use CT or MRI because it would be more reliable. If your diagnosis is early onset Marfan syndrome, we do recommend cardiac and neck MRI, looking for tortuosity of the blood vessels in the neck. But you can see on this table here that there are indications for doing it at baseline, when the diagnosis is made, as well as when to do it during follow-up. In Marfan syndrome, it's pretty common to need CT or MRI in adults, right? So, and that's partly because the area is bigger in adults, but also because it's harder to get echo imaging sometimes. So we would use CT and MRI more commonly in adults with Marfan syndrome as compared to children with Marfan syndrome. The reason to do CT or MRI in other diagnoses, like vascular EDS or Loeys Dietz, is because there's a higher chance that be an aneurysm or an enlargement of an artery that we can't see by echo, right? So if you have a chance, if you have a higher risk of having, say, something in your neck or in your head or in your abdomen, such as in some forms of Loeys Dietz syndrome, then we would definitely need to do a CT or MRI. And how frequently we do it depends on your diagnosis and what we find on the first study. So if we find something abnormal on the baseline study, then we're more likely to do the follow-up studies more frequently. But that will depend on your diagnosis as well.
Yep. So Dr. Lacro is pointing it to this is the indications for imaging. This is who gets imaging at baseline versus follow-up. And then regarding the echo, there's this of what echo to get at baseline. X is mandatory, and then there's like optional and versus follow-up. So we have both for imaging and for echo and for CT MRI. And CT and MRI were used pretty interchangeably in the statement. We do make some in the statement, some distinctions of when one is better than the other, but most of the time we're talking about either.
Great. Thank you. Is atenolol the preferred treatment for children 4 and under?
The data, and I'll be curious to hear Dr. Lacro's, the data for atenolol under 4 is pretty minimal. And so in our practice, we tend to use propranolol for very young kids that need a beta blocker and then switch to atenolol at age 3 or 4, because that's when we have better data. I don't know about you, Dr. Lacro.
Yeah, so the Pediatric Heart Network trial actually used atenolol as young as 6 months. And the other arm, so we use atenolol or losartan in those children and young adults in the Heart Network trial. So I have used atenolol in younger patients. I mean, in very young infants, we often will start with propranolol.
Thank you. In the statement, you mentioned dual therapy if tolerated. What does if tolerated mean? What are indicators to change medical management?
Well, I think I'll start and then you can supplement, Shaine. I think when we suggest dual therapy, what we're suggesting is that what we're recommending is not just a little bit of this and a little bit of that. We want full dosing of each of the drugs, right? So we don't want, underdose for one or the other drug. So what we would recommend is going up to a full dose of one of the medicines before adding the second drug, and then increasing the dose as tolerated to the maximum amount. Now, there are some patients that cannot tolerate one or the other, and so it's hard to put them on dual therapy. So it's based on tolerance level of the patient. If one drug is all that the patient can tolerate, then that's what we would recommend.
Yeah. And by tolerance, I think, some people will get really dizzy on it, or they'll have side effects from one or the other medication, whether that be headaches or nausea, or people who have severe asthma or eczema may not be able to take beta blockers. And so, but we are trying, there is really good data now based on a compilation of multiple trials that they have additive effects, that beta blockers and angiotensin receptor blockers, which losartan and atenolol, respectively, those groups, that combined, they have a better effect than monotherapy, at least in those patients that have a reasonable degree of dilation in Marfan syndrome. That's the only group that we've tested dual therapy in, but it does seem to be better than monotherapy for patients that have a reasonable degree of dilation. So that's why we aim for using both if possible.
Okay, great. Here's a question that touches on the ethics of disclosing diagnosis. If an adult has genetically confirmed heritable thoracic aortic disease and they don't think their children need testing, and the children do not know of their parents' HTED diagnosis, how is this addressed ethically both in children under 18 and over 18?
This has happened to me. I really try to encourage it by telling stories to encourage disclosing early. I will say it's a lot more traumatic if you're 15 or 16 or 17 and have developed an identity. And then now you hear that you have this chronic medical condition. If you're diagnosed late, it's extremely hard. And there's a high rate of adjustment disorders or depression when you tell someone late that they have it versus if they know when they're young, they just grow up with it being part of me, especially if a parent has it because they have it too, and you're just special and you're different. I think it's really, really hard if you have the choice for a teen to learn this because they've found out what their loves are. They have a self-identity. And I mean, it is a parent's decision to disclose that, but I really work hard with parents to try to disclose as early as possible. And you don't have to say you have this major medical condition that's called this name. You might just say, your tissues are a little different or they're a little special or your skin's a little different. And so we need to be on medications or we need to avoid these certain things because just like redheads shouldn't be out in the sun too much, like it's just a difference like we all have and making it as special and a difference rather than like a major medical condition.
Thank you. Dr. Lacro, did you want to weigh in?
Yeah, I'll add a little bit. I mean, I again, like Dr. Morris, I really try to work with the families, try to figure out what their concerns are, what their fears are, but I think knowledge can be powerful and life-saving even. It also depends on the diagnosis and if the child should be screened. If the child has the condition, then they should at least get echoes. And then the management's going to depend on what you find on those echoes, right? And I found it's like I have had families where they just didn't really want to talk about the diagnosis, even though the child was coming for echoes every year. And it's a little bit awkward to be in that situation. I mean, obviously, you work with the family and the patient. But the most important thing is to make sure that, nobody's, that the risk is being recognized, right? And that if the aorta is enlarged, that we're managing it appropriately. I mean, I think with a diagnosis like vascular Ehlers-Danlos syndrome, I think it's very important, as difficult as it is, to sort of broach that subject and notify a child that he or she might be affected. I think it's going to be important for his or her long-term health to really learn early about the condition that they have. Sometimes there's concern about, the range of severity, and oftentimes we can reassure them that they're actually better off understanding and knowing what the diagnosis is. But it is a situation that over time, hopefully we can manage.
Great, thank you. We're going to just take one more question. If we didn't get to your question, please feel free to reach out to the Marfan Foundation's Help and Resource Center at marfan.org/ask. Our last question, how often do you see complications in the aortic arch?
I can start with that, and then if Dr. Lacro wants to answer after. I will say, if we're talking about Loeys Dietz, or Marfan, it tends to be, it's not uncommon, but it tends to be later in older patients and going near into adulthood. Like the most common times we see arch issues, besides mild arch dilation, that can be really common, but is more of someone who's had a root replacement or has more severe form of disease, then they might have an arch dissection or aneurysmal dilation of the arch, or filament A, they get aneurysmal dilation of the arch, but it tends to be a little later, like teen years most commonly, except like in the very most severe forms of Loeys Dietz. Now, there's certainly these ultra rare ones like EFEMP2 and arterial tortuosity syndrome. They get coarctation of the aorta and narrowing of the arch, as well as dilation of some parts of the arch. So they can be born with congenital coarctation. and same with bicuspid valve. So that's kind of a different subset of arch disease. I think you were probably talking about the prior.
Yeah, I agree with that. I mean, it would be unusual to have isolated, there are cases, but it's unusual to have isolated arch dilation without, sort of aortic root involvement. And we often see it in patients as they get older who've had, more proximal or root problems, especially if they've needed surgery. But yeah, we pay attention to the rest of the aorta as well and the other blood vessels. Again, a lot of these questions that I'm seeing in the Q&A are very specific for your child and your child's specific situation. And what I would recommend is you just, talk with your local provider and sort of figure out where your child fits in this sort of general framework. And hopefully the statement will be helpful to you and your providers.
That's such a great wrap up. Thank you. Let me just pull up one last slide. Okay. Many thanks to those in our audience who submitted questions, and obviously to our speakers for so thoroughly addressing them. It is very much appreciated. Before you go, please take a moment to share your feedback on this webinar by visiting marfan.org/survey or scanning the QR code on your screen. Again, thank you so much for joining us today. Take care.
Thank you, guys.
Thank you.